सुखिनः
सर्वे भवन्तु सुखिनः
सर्वे सन्तु निरामया
सर्वे सन्तु निरामया
सर्वे भद्राणि पश्यन्तु
सर्वे भद्राणि पश्यन्तु
मा कश्चित् दुःखभाग् भवेत्
मा कश्चित् दुःखभाग् भवेत्
न त्वहं कामये राज्यं
न त्वहं कामये राज्यं
न स्वर्गं न पुनर्भवम्
न स्वर्गं न पुनर्भवम्
कामये दुःखताप्तानां
कामये दुःखतापानां
प्राणिनाम् आर्तिनाशनम्।
प्राणिनां आर्तिनाशनम्।
आज का हमारा साइंटिफिक सेशन हेडेक पे है और उसके लिए मैं डॉक्टर पीसी शाही साइंटिफिक सेक्रेटरी को बुलाता हूँ।
Good morning everyone. It's a pleasure to welcome you all to this CME on headache history taking. As we know, headaches are one of the most common complaints in clinical practice, yet they can range from a minor inconvenience to a symptom of serious underlying conditions. To provide the best care, it's crucial that we as a healthcare professionals master the art of history taking when it comes to headache. And today's session will focus on how to effectively gather and interpret the patient's history to guide diagnosis and treatment. We are fortunate to have with us Dr. Manish Gupta, who is MBBS DNB medicine in TMH. He did his MD medicine from TMH Jamshedpur and currently practicing at Paki Hospital as a consultant medicine. And he is having extensive experience in neurology and headache management. Dr. Manish Gupta will guide us through the key elements of history taking of headache, including how to identify red flags, differentiate between primary and secondary headaches, and the importance of understanding the patient's experience. And without further ado, let's dive into this important topic. Please join me in welcoming Dr. Manish Gupta. Thank you.
Good morning, seniors and dear friends. Today we'll talk about how to take a proper history in patient who comes up with headache. Now, headache is one of the common presentations in our day-to-day practice. As Dr. P.C. Sai rightly told, it could be somebody who comes with very trivial signs and symptoms of simple headache to very debilitating conditions such as cluster headaches which cause a lot of pain and discomfort to the patient. Now, when the patient walks into you with headache, you must remember that eliciting a good history is very important, right from since when does what kind of headache does he have and how did it start, because first of all when the patient comes to you, maybe he has been having headache for since a long time and he has come to you because it has either aggravated or it has got some other discomfort from his usual presentation. Now, there are certain conditions which are known as red flags in history presentation, in headache presentation. Red flags generally they tell you that the condition is not benign and there is a secondary cause to it which has to be investigated and dealt with thereon. So, the condition could be first presentation on which the patient has severe thunderclap headache or a new onset of severe headache which are over 50 years of age, in patients with 50 years of age. Then you have headaches with acute glaucoma, then you have headaches with meningeal signs, then you have intractable headaches and headaches which have atypical aura or atypical focal signs. These are all secondary causes of headaches which needs to be investigated properly, and they are far more serious than your primary headaches. Now, in primary headaches you have basically three kinds of headaches. First is migraine, second is cluster headache, and third is trigeminal associated headaches. Apart from that, all the other headaches are actually classified as secondary headaches. So, when the patient comes, first question that you should be asking him is, since how much time did you have your headache from? I mean, some of the headaches like migraine, they can have a very chronic history that the patient has been having headache for a long time. Now he's come to you because of it has actually precipitated or it has changed in character. Then second thing would be, you should be asking is where does the headache radiate to? Now migraine is usually unilateral to start with, and then it can become generalized. Now migrainous headaches, they are actually associated with throbbing, pulsating type of headaches. They are actually build up very gradually. They last from 4 hours to 72 hours, and they are associated with they can be associated with aura, which can entail vomiting, then the photophobia, phonophobia, nausea. Now in headache, you have to also ask the patient about the frequency of headache. That is, how frequent is the headache, how many times in a day does it occur, whether it occurs daily or whether it occurs once or twice in a week or whether it's monthly. Then you have to ask about diurnal variation of headaches. That is, early morning headaches are usually there in patients who are obese, who have obstructive sleep apnea because of cerebral vasodilation in response to raised CO2. Secondly, there are also patients who have uncontrolled hypertension who have early morning headaches, and also patients who have increased intracranial tensions. Apart from that, there are certain headaches which wake an individual from sleep, such as hypnic headache syndromes, cluster headaches, and SUNCT syndromes. SUNCT is short lasting unilateral neuralgy form headache with conjunctival injection and tearing. It's a pretty long term. Now coming to the next one. Now tension type of headache. Now tension headaches are generally dull aching, they are bilateral, then they do not have any special character such as throbbing or pulsating type, and they are actually related to your stress. So this is a proper tension type headache. You can see the entire forehead or entire skull is involved anteriorly. Now cluster headaches. Cluster headaches, they are actually they are a type of trigeminal autonomic neuralgias in which the patient complains of rapidly occurring or rapidly progressing headache, which is localized to one side of the head, generally around the orbits, and then they also have certain autonomic features such as lacrimation, nasal stuffiness, conjunctival injection marks, or sometimes even a few features of Horner's syndrome. Now coming to severity of pain. Now in the severity of pain, you have to ask the patient to classify his painful condition of headache based on visual analog scale of pain from 1 to 10. Now generally cluster headaches and migraines, they range anywhere from 9 out of 10 to 10 out of 10 on a visual analog scale, whereas tension headache is mild dull aching, so it is somewhere between 3 to 5 upon 10. And the important thing is severity of pain does not tell you whether it is a primary headache or a secondary headache. Just like we have talked, pulsatile throbbing or hammering pain is a typical in migrainous kind of headache. Ice pick pains or burning over the face, they are all typical of trigeminal neuralgias. Migraine pain, it builds up gradually, whereas cluster headaches, they are rapid in progression. Now environmental factors, dietary factors and hormonal factors, they all tend to affect your migrainous headaches. Menstrual cycle increases migrainous headaches. Pregnancy, second and third trimester, the migrainous headaches, they tend to become milder. Seasonal variations are seen in cluster headaches. Now just as we talked about, there are certain accompaniments of headaches, such as in migrainous headache you have vomiting, photophobia, phonophobia. These features can rarely be seen in meningitis as well as subarachnoid hemorrhage, which are the secondary causes of headache. Autonomic features such as nasal stuffiness, lacrimation, or ptosis along with other features of Horner's syndrome, they are typical of trigeminal autonomous cephalgias. You will find tender superior temporal artery in giant cell arteritis, which is again one of the urgent conditions to deal with. There are certain non-painful stimulus which can give rise to pain over the scalp, which are known as cutaneous allodynia, such as combing of hair. If somebody has a long hair, he will say that he feels better when he lets his hair down. Difficulty in combing or exposing his head to cold or warm air. Depending upon how severe is the pain, the disability is calculated as per Midas score. I will just tell you a few lines about Midas score. Midas score would be that how many days in last 3 months has the patient not been able to do his professional work. Since how many days in last 3 months the productivity at his professional place has not been up to the mark. How many days since last 3 months he was not able to carry out with his household activities normally. How many days in last 3 months was the productivity in his household activity less than optimal, and also how many days since last 3 months he has missed any kind of recreational party or gathering which the family or his friends were having. Now here are certain other conditions in which you have certain headaches which worsen on doing certain activities. Valsalva's maneuver, coughing, laughing or sneezing, they all tend to raise your posterior cranial fossa pressures. So you must rule out posterior cranial fossa causes or craniovertebral junctional anomalies. Sexual activity which worsens the headache could be because of subarachnoid hemorrhage, dissection of the cervical artery, or it could be a primary sexual headache. Postural worsening of headaches, if the patient who's standing goes to lies down, if the headache increases, probably he has increase in intracranial tensions. Then there are certain headaches which worsen on exertion, such as cardiac cephalgias, pheochromocytomas, dissection or primary exertional headaches. Now cardiac cephalgias, they actually have, these patients have CAD, and the moment the patient starts exerting himself, the demand of the blood supply to the heart is compromised, and similarly in the same line he also develops headache. As you treat the cardiac cause, the headache also tends to come down. Now you have certain personal history which are very pertinent in headache patients. If the patient is somebody who takes alcohol, probably he will be having more attacks of cluster headaches. Excessive tea and coffee again causes headache. Sleep habits and disturbed sleep, they can precipitate both cluster headaches as well as migraine headaches. Then you have medicine overuse headache. Now medicine overuse is something which is often missed. Now medicine overuse is it is actually defined as a person who has been taking triptans or opioids or ergot derivatives for more than 10 days in a month, or NSAIDs for more than 15 days in a month. They are supposed to have these medicine overuse headaches, because what happens is once you stop these medicines, tell him no, you don't take this, they tend to have a rebound headache which is far more worse than his primary headache. So it is a kind of dependency which the patient has on these drugs. Now thunderclap headache, which is again an emergency, is found in subarachnoid hemorrhage, sentinel headaches, ischemic stroke, pituitary apoplexy, cervical artery dissections and acute hypertensive crisis. Now coming to chronic headaches is a headache which occurs for more than 15 days in a month for more than 3 months. So for classifying any headache to be a chronic headache, 3 month criteria is there. So if it is more than 4 hours, if the headache lasts for more than 4 hours in a primary type, it is likely a trigeminal autonomic cephalgia or a sexual headache or a cough headache. Less than 4 hours, chronic migraine, chronic tension type headache, new persistent daily headache, and hemicrania continua. Apart from that, you have secondary headaches which have to be investigated, in which you have a treatable cause, you can treat them. Most of the primary headaches, they do not have a cause, and also primary headache is one of the most common headache. More than 90% of patients who present with headache, they have primary headaches. There is another thing, you have certain kind of headaches which respond typically to your indomethacin treatment. Now this is chronic persistent headache. Then you have hemicrania continua, Valsalva's maneuver induced headache, primary cough headache, and primary stabbing headache. They all respond to indomethacin. Some of them can be totally stopped. The mechanism of indomethacin is not very clear how it acts, but possible mechanisms are inhibition of cyclooxygenase, reduced cerebral blood flow, and inhibition of nitric oxide. Secondary causes of headache, their main contributors are conditions in ear, nose and throat speciality, and also ophthalmic conditions. So here are certain medications which can be used for treatment of acute migrainous headaches: metoclopramide, chlorpromazine, prochlorperazine, chlorpromazine. Then you have diphenhydramide, sumatriptan, zolmitriptan, ketorolac. Apart from that, the Canadian Association, it says that for acute treatment of migraines you should use NSAIDs such as 1 gram of paracetamol or 500 or 550 milligrams of naproxen and ibuprofen 400 milligrams, followed by triptans, 100 milligrams of sumatriptan, then rizatriptan 10 milligrams. Subcutaneous injection of sumatriptan is available, which can also be given. Then you have fixed line combinations. Now the question comes, when should you put the patient on prophylactic treatment of migraine? Now you have a patient who has not responded fully to your acute treatment, somebody who is having very frequent headaches, and somebody who's got a debilitating aura, or somebody whose dose of treatment per month nears the medicinal overuse criteria. In such patients, you should try prophylactic treatment with either beta blockers, amitriptyline, nortriptyline, topiramate, valproex, and even botulinum toxin A. Now you must tell the patient that it is going to take 4 to 8 weeks before you have measurable effects of your prophylactic treatment, and also 50% remission of the symptoms which previously he had despite his acute treatment is considered good enough in prophylactic treatment. For cluster headaches, for tension type headache, you have NSAIDs, then you have amitriptyline, mirtazapine. Apart from that, you must also tell them to do certain relaxation activities, decreases the kind of tension that he is going through. Certain leisure activities he should indulge in, certain physical activities he should indulge in. Then for cluster headache, you have subcutaneous sumatriptan, intranasal zolmitriptan, 100% oxygen for 15 to 15 liters per minute for 15 minutes, verapamil, lithium. There are certain other non-pharmacological treatment for migraine treatment, such as maintaining a headache diary, increasing hydration, regular sleep, regular exercise, cognitive and behavioral therapy, biofeedback. Then avoid medicinal overuse. Then do not use over-the-counter drugs more often. Then you can have certain supplements such as magnesium, riboflavin, melatonin, which actually there are certain home remedies, essential oils, open your windows, eat a healthy snack, take a nap, certain herbal treatment. So ultimately somebody who comes to you with a headache which builds up gradually, is unilateral, has certain accompaniments such as photophobia, phonophobia, nausea, vomiting, then you must consider the diagnosis of migraine. If it occurs for more than 15 days a month, then you can classify him as having chronic migraine, and you can treat him with prophylactic treatment along with acute treatment as and when required. Now somebody who's got a dull aching headache which is bilateral and has no special features such as pulsating or throbbing type, not very severe, then probably he or she is having tension type of headache. Thirdly, if somebody comes to you with a headache which is initially unilateral, builds up very quickly, is around his orbits, has nasal stuffiness, then lacrimation, then ptosis or facial swelling on one side, then you must think about cluster headache. Apart from this, you have something called as hemicrania continua, which is one unilateral headache, and it is continuously there ever since the onset. Now the special thing about this headache is, this headache typically is a response to indomethacin, and probably indomethacin in certain studies they have showed that it abolishes the problem completely. So with that I will wrap up. Thank you so much for your kind listening.
Psychiatric disorders associated with headache.
See, there are a lot of any psychiatric disorder for that matter can give rise to headache. Even you have drug induced psychiatric disorders, one of the most common would be increased anxiety causing headache.
What are the features?
Features of what?
How can you differentiate psychosomatic disorder?
You'll have to take the proper history. No, in psychiatry you have to take proper history.
Typical features they are
All secondary features, anything which you find in your MRI or CT will only be there for will give rise to a secondary cause of a headache. In all these studies, in all imaging studies, there have been no known causes for primary headache types.
मूड डिसऑर्डर बहुत कॉमन होता है, किसी भी साइकेट्रिक डिसऑर्डर में मूड डिसऑर्डर
बिल्कुल।
बहुत कॉमन होता है, किसी भी फॉर्म में इरिटेबिलिटी से लेके लो मूड तक, किसी भी चीज में इंटरेस्ट कम होना इज वेरी कॉमन इज दैट.
आपके
What is the duration of treatment of headache in migraine and cluster headache? And one thing more about secondary headache.
Yes, sir.
So many cases.
Yes, sir.
You have not gone through any one of.
No, sir. I've told about the red flags which are actually.
What is the red flag symptom? Then we have to tackle it. But
Sir, I'll tell you, sir.
Red flag symptoms. It doesn't mean how you can go.
Okay, sir. I'll just tell you about that also, sir. Because so the list is endless for a secondary.
हम लोग ऐसे भी बात कर सकते हैं. आप लिटरेचर उसको छोड़ दीजिए. आप ऐसे भी बात कर सकते हैं कि जैसे हेडेक का पेशेंट अगर आ, तो सपोज करिए एक हेडेक के पेशेंट आ रहा
हाँ
है,
सर.
वो सडन सीवियर थ्रॉबिंग बस्टिंग इस टाइप के हेडेक का प्रेजेंट कर रहा है, तो आपको ये चीज देखनी
Cluster
पड़ेगी भाई वो सब अगर ब्लड प्रेशर का पेशेंट है या कोई ऐसे पेशेंट है तो वो सबएक्यूट हेमरेज के चांसेस उसमें बनते हैं. या अगर पेशेंट को पहले से पारिक्सिया चल रही है, कंफर्मेशन चल रही है, उसके संग आपको नेग्लिजिटी और
मिल रही है तो मेनिंजाइटिस हो गई. हाँ
तो आप ये मान के चलिए कि वो मेनिंजाइटिस या इस तरह की चीजें हो सकती हैं.
सर, मैं बोला था.
ठीक.
हाँ सर.
और सेकेंडरी कॉजेज में क्या है कि मेनिंजाइटिस हो गया,
मेनिंजाइटिस हो गया, एक्यूट
स्पेस ऑक्यूपाइंग लीजन
ओवर 50 इयर्स, वो 50 इयर्स में.
इसमें ज्यादातर मॉर्निंग हेडेक ज्यादा होता है, प्लस इट इज
Behavioral changes also. हाँ सर.
पहले वॉमिटिंग होगा फिर हेडेक. तो ये चीज़ें मतलब ये सब छोटी छोटी चीज़ें हैं जिसको आप ध्यान रखेंगे।
बिल्कुल सर।
क्योंकि एक्चुअली ठीक है, प्राइमरी काजेज आपके 90% है, आपने बोला ठीक किया, मगर जो 10% काजेज है अगर उसमें उस वक्त अगर मिस कर गए तो फिर वो चीज़ आप नहीं कर पाएंगे, तो हम पेशेंट को कैसे डील करें।
सर उसमें
ड्यूरेशन ऑफ ट्रीटमेंट इन माइग्रेन एंड क्लस्टर दोनों अलग अलग डिफरेंट है। क्लस्टर में कंडीशन इज द मेन काज और माइग्रेन में वैसोएक्टिव सब्सटेंसेज
Yes, sir.
मेन काज। वैसोएक्टिव सब्सटेंसेज को आप कभी भी खत्म नहीं कर सकते, तो उसमें प्रोफिलैक्टिक ट्रीटमेंट जैसे आपके हिसाब से लगा कि आप 4-5 हफ्ते दे करके उसको सबसाइड कर देंगे, एक्चुअली रेमिशन उसमें नहीं होता। इफ इट इज ए माइग्रेन हेडेक तो उसमें आपको
देना पड़ेगा, देना ही पड़ेगा।
so many years। फीमेल्स में तो ज़्यादातर 45-50 ईयर्स तक चला जाता है।
हाँ सर।
मेल्स वाले तो चलो भाई किसी तरह से डायल्यूट हो जाते हैं, मगर फीमेल्स में लंबा जाता है। ये सब चीज़ें थोड़ी थोड़ी कंसीडर करें।
यस, थैंक यू सर। सर
Up to what age migraine headache can occur? From what age range?
So generally-
किस एज तक माइग्रेन का हेडेक जा
So generally it is seen in younger people, but it can occur up to 50-55 years of age, sir.
But
हाँ, sir.
range.
हाँ हाँ सर।
के बाद क्यों माइग्रेन का अटैक कम हो जाता है?
शादी हो जाती है तभी आ जाता है। सर सेकेंडरी कॉजेज में सर जैसे सर
ट्रिपलिंग मतलब हेडेक टू डील विद हेडेक इज आल्सो हेडेक। एमिट्रिप्लिन जो ड्रग है, इस ड्रग के साइड इफेक्ट इतने ज़्यादा हैं कि साइकियाट्री में जो डिप्रेशन की ये मेन दवा होती थी 70s में, हम लोग ने एमिट्रिप्लिन 75 125
Yes, sir.
मिलीग्राम पर डे तक यूज किया।
हाँ, इसमें 100 तक बोला गया सर, नहीं होती थी।
मगर अब आप 25 मिलीग्राम भी देते हो तो पेशेंट हमेशा वो ड्राइनेस और मतलब सो मेरे एंटीकोलिनर्जिक इफेक्ट्स उसके आ जाते हैं।
बिल्कुल सर।
तो अब एमिट्रिप्लिन अभी भी सब जगह है, तो कितना मिनिमम डोज तक एमिट्रिप्लिन रखें कि वो चीज भी ना हो
सर,
अभी चल जाए।
सर,
मतलब इसमें
10 मिलीग्राम से शुरू करना है सर।
कभी 15 मिलीग्राम लेना है, कभी 25 मिलीग्राम, तो एग्जैक्ट कोई
सर 10 मिलीग्राम से सर 10 मिलीग्राम से शुरू करना है। एंड अगर पेशेंट टॉलरेट कर रहा है और आपको डोज बढ़ानी है तो वीकली 10 मिलीग्राम्स का डोज बढ़ाना है सर। इसमें ये मैक्सिमम 100 तक जा सकते हैं सर।
एमिट्रिप्लिन सबसे बड़ी प्रॉब्लम इंटॉलरेंस का।
बिल्कुल सर।
सेडेशन की थोड़ी बहुत प्रॉब्लम
सेडेशन है, ड्राइनेस,
बाकी टॉलरेंस वाला तो चल जाता है, मतलब 75 तक चल जाता है, 75 के बाद दिक्कत
सेडेशन क्या ड्राउजीनेस, बहुत लेजीनेस फील होती है आप बिल्कुल।
जो उसके एंटीकोलिनर्जिक इफेक्ट्स हैं वो बहुत ज़्यादा
और सर वो 75 के बाद ही थोड़ा सा ज़्यादा कॉमन दिखते हैं हम लोग, मतलब साइकियाट्री वाले हम लोग ज़्यादा यूज़ करते हैं, इसलिए जनरल में ज़्यादा
Cool. Thank you, Dr. Manish, for a very insightful presentation. Actually, headache is a very vast topic, and I think you have just set the context, and probably will have more presentations on headache in near future. So I think it's time for the quiz presentation. To please select the candidates for answering the question.
Which type of headache has autonomic features?
So first raise your hand and answer. Doctor?
Cluster.
That's correct sir.
That's correct. A big applause.
Which headache is indomethacin responsive?
Hemicrania.
Sir, no, just Doctor.
Second, hemicrania.
No, that's not the right answer.
All of them.
Yes ma'am, all of the above.
okay. बहुत बढ़िया. चलिए.
Headache when one wakes up is caused by?
Raise your hand. हाँ, डॉक्टर प्लीज.
All. ठीक.
All is the correct answer. आप पूरे ऑप्शंस पढ़ दीजिए.
Headache, medicine overuse headache is also known as drug induced headache, rebound headache, dependence headache, withdrawal headache. It's a rebound headache sir.
Sir, Dr. Gupta.
Rebound headache sir.
So
I get the praise.
Just okay. okay.
Horner's syndrome is a feature of
Just read it.
classical migraine, migraine without aura, tension type headache, trigeminal autonomic cephalgias, cardiac cephalgias.
Raise your hand, ma'am.
TAC, yes ma'am, it's TAC.
Tax. Wow, क्या बात है, बहुत बढ़िया.
Thank you so much.